Hello, I'm Dr. Basil Considine, and today we're going to be talking about a subject that will be of interest to anyone on a pre-med pathway, anyone who is interested in precision medicine, or generally in the wonderful and exciting directions in healthcare today. We're going to be talking about rounding and treatment boards, and we'll be looking at an assignment coming from a precision medicine course, but using this as an entry into understanding a topic that is really, I would say, one of the most exciting areas in cancer research today and in patient-centered therapies. Customized, sometimes involving things that would have just been unimaginable even 10 years ago that are now very accessible, very customizable, and giving people a great shot at life or improved quality of life over the course of their illness. So let's talk today. We have three basic objectives. We want to understand the role of a treatment board, to discuss the sample assignment that's going to be coming from PCM 605, and we'll explore how to implement the instructions for this in creating a content outline. Now, this particular assignment that we'll be looking at asks that you prepare a PowerPoint presentation, which is how most treatment board initial presentations go. Whether you're a medical resident or a fellow, or you are a part of the group of attending and other physicians at a hospital, or a nurse expert or some other specialist. These are things that there is a customary order to orient people to the topic, to state what has gone before, to identify potential avenues, what is and isn't working, what are the known things about the patient, and to propose a treatment leading into the larger discussion. And because these are all people who are very busy and are often making special time to meet together before they go to their own respective specialty areas, this is something where the standardized format is really important as a skill that people practice. So, let's talk about treatment boards. So, what is a treatment board? Well, it's essentially a group of physicians and other healthcare providers that meet to discuss patients that, for whatever reason, their cases are more complex. They might have comorbidities. They might have something like cancer, which has many subdivisions. They may have a resistant infection. But they're meeting to discuss these cases, to share knowledge about that, sometimes about the patient, sometimes about related things, sometimes about new developments in the literature, because there's a lot to keep track of, and ultimately to help decide and inform the course of treatment. Now, sometimes a treatment board decides to proceed as has already been done for want of a better option, or because they need to stay the course to determine whether something is efficacious or not. But the goal is that you're not just having one person saying, okay, that didn't work, scratching their head, and then giving their best guess, but you're enlisting a panel of specialists, and specialists can be both in the medical specialty sense, or also people who have particular expertise in this environment or this population, for example, because a patient may decline treatment in some area for their own reasons, and you want to respect patient choice. Now, this is particularly common in cancer cases, and especially using precision medicine, which again is one of the most exciting things going on in healthcare now, because so much has changed in terms of accessibility, speed, cost, that makes things that even the President of the United States wouldn't have been able to get 10, 15, 20 years ago, are now common enough to get in a major city or at a university hospital. Now, one particular type of treatment board, the tumor board, has a history now in the US of more than 50 years, and these are increasingly multidisciplinary in nature because we are having an improved understanding of how to address the many iterations and variations in cancer. So let's talk a little bit more about those tumor boards, because they are actually highly relevant to the assignment that we're going to be discussing. There has been a greater understanding and availability of information about experimental treatments, and so what might have been a study that was doing a drug trial for a very particular genetic disorder that only took place near that university hospital or at the National Institutes of Health in the United States can, due to many advances, now take place anywhere across the country, and sometimes in other countries where a special treatment is flown in or a team of specialists go, and you have greater access to certain surgeries. So something like Moore surgery was a lot harder to find a specialist 10 years ago, and now it's become a wonderful training thing where they can really do real-time or close to real-time diagnostics while removing the tumor with good margins, but doing the least harm to the surrounding tissue by taking as little of that as possible. And so these are things that they're simply more available, and it gives more opportunities. At the same time, we have an increase in our understanding of the biochemical fundamentals underlying cancer and the therapeutic targets that different therapies, radiation, chemo, drug, things like monoclonal antibodies. I remember reading about those in Newsweek magazine as a youth, saying that, if only the cost would come down. Well, they're not cheap, but the cost has come down, and that lets us do things where you have advances in things like genotyping, which is now you can test for very particular variants that can have a profound effect on the course of cancer therapy. And the knowledge of that, the databases of these things are constantly evolving and expanding. And sometimes it's being revised when we discover that something else is associated with the things we first associated with something else. We also have an increased understanding of what we call de novo mutations. So when something that doesn't appear in the family history is found in a child, or perhaps the child has grown to an adult, we have an increased understanding of how, in the course of a cancer, how there's an accumulation of mutations which may cause there to be a failure, weakness, or opportunity in treatment. So that the same treatment working at different stages of a cancer or a stage of an illness in general may not work because of these mutations. And in a few cases, it may become more responsive to a treatment because of that. And so, as I was alluding to earlier with the discussion of Moore surgery, there's a coordination now, much more so than before, because there may be certain specific targets. The surgeon who would be tasked with doing the Moore surgery wants everything that can be done to shrink the tumor up to a certain point where you have diminishing returns. And so you're trying to do a combination to get the patient to that point. Now, to pick an example that many of us have become all too familiar with over the last 3 years, if we're looking at COVID-19, there are a host of different targets that can be used when you are looking at this, because if we see how the virus gets into the cell, and in fact, the things within the cell that you might target to try and shut things down, we have a large swath here. And this is one of those reasons why there are different vaccine efficacies and why vaccines might need to be updated or reformulated over time to accommodate mutations. You probably remember Delta and Omicron mutations and the discussion of a need to update the vaccines, and that's where we get that bivalent booster and things like that, because some of these therapeutic targets may change. And one of the reasons that different vaccines develop in different countries and by companies around the world have different efficacy in helping avoid or reduce the impact of COVID-19 infections is because they're hitting different targets and stimulating the immune system in different ways. Now, this happens to be coming from Signal Transduction and Targeted Therapy, which is a great journal and relatively recent as they go. So if you did some training earlier in your life, you may not be aware of this, but it is a great journal for following different targets and how you might be informing therapies around that. Now, if we pick one type of cancer that tends to develop solid tumors, sarcomas, we can see that similarly there are a lot of different targets we can hit. So you can see that we've got, for example, in the upper left-hand corner, we have the last thing in the box, bevacizumab, that is a monoclonal antibody, as you can tell from the MAB at the end, and that is specifically targeting things in the VEGFR pathway. Now, if we go look at the right-hand side, the second box there, we have various inhibitors for mTOR, which is another one of our signal pathways here. On the left-hand side, you can see there's a variety of things. There's a selection of monoclonal antibodies to shut down PD-1. There are things that target things with macrophages. We have T-cell-based therapies. So there is a wide variation. And so when you are discussing a patient, if treatment is not working or has stopped working, it's important to go through what has been used before and how recently, because that may give you an idea of progressive mutations that may cause you to stop targeting one thing. So for example, let's say the patient has been receiving sirolimus, which is an mTOR inhibitor. That might be something where accumulated mutations over the course of a metastasing cancer, and you're saying, okay, this doesn't seem to be working. We could try another mTOR inhibitor, but what if we switch to a different class? And you want to check, of course, to see if there are any patient mutations that may inform your response there. But you might say, all right, we want something that now targets MDM2. And that's about finding something where the available drugs are still able to do the thing we want. It's just doing it at a different point in the life cycle of a cancer cell, such that we're able to get effective results, even though something else is perhaps mutated beyond the easy ability for us to target with an existing class of drugs. And you'll note this is also coming from that same Signal Transduction and Targeted Therapy journal. So let's take a look at the sample assignment here. And this is coming from the Molecular Targets and Precision Medicine course. And the assignment asks you to prepare a mock Molecular Tumor Board presentation. And it begins with a brief preamble. Molecular tumor boards are now an important part of the oncology continuum of care. Discussions include various specialists, oncologists, radiologists, genetic counselors, pathologists, and cancer biologists. Yep. And then we move into the main instructions, starting with this overarching note. This assignment is to devise a tumor board presentation that will be used to discuss a made-up patient's clinical course. So you design the patient that you'll be discussing. And then in the course of your presentation, you have 5 specific things that you're supposed to do. To present the patient's clinical diagnosis, their treatment history, including the current regimen, what molecular profiling has told us at an earlier point and where we are now, the proposed resistance mechanism. So if all was going well with this patient, you probably wouldn't be discussing them with the tumor board. So something has broken down in the treatment process. And if we were looking at this graph again here, and let's say you were giving them, let's say that they were on apatinib and that was working very well, and then after they had a regression, cancer cells, the tumor started enlarging, and you're like, oh, and so we tried switching to regorafenib and it didn't work, and we tried switching to bevacizumab and it didn't work. Well, there's probably something why all of 3 of those VEGFR drugs didn't work. So it comes to discussing the proposed resistance mechanism, you're looking at the combination of what they have, the diagnosis, the treatment history, including what's working, what's being used and what's being given now, which may not be working, which is often the case while you're with the board, and then what the molecular profiling has told you, or what you are looking actively to find. So you might have some more tests that you're sending out. And proposed resistance mechanism, this is what you think might be going on. And then with that, well, what new therapies should you be considering for the next line of treatment for the patient? Now, in this example here, I've just pulled something for sarcomas. But with any cancer, whether we're talking a lymphoma or a, let's say, non-small cell lung cancer, probably not leukemia, because leukemia tends to not have as solid tumors as much. It's not impossible, but tends not to as much. If you're talking, the big three or so that create solid tumors, you'll have a variety of different options available. Surgery is generally not, except for some certain complications, surgery is generally not as helpful in leukemia, because you can't just target, oh, hold on, we've got this little spot inside this bone. You generally have to use systematic chemo of some sort. So the exact disease will inform the options on the table. This assignment is specifically dealing with a tumor, so think solid tumors. And we're being asked to create a slide deck that has between 6 and 8 slides with citations on those slides of where the information is coming from, and a reference slide that lists all of them. That's probably just going to have a bunch of stuff in a smaller font. But the purpose is, if someone has a question like, well, why did you do that? Why are you recommending this? If you have your parenthetical citation with that bullet point on the slide, oh, it's such and such a study, and you can always go to the reference slide for people to get more information on that, but you know where to point as that as a source. Some more information about how this presentation should work. Well, you need to be showing that you understand that the clinical course of treatment involves progression of multiple treatments and lines of therapy, and that molecular profiling can and should be, in this case, used to identify a targeted therapy, not just at the start, but as you go forward, because mutations may accumulate, or mutations that you did not test specifically for before may explain a failure in treatment. And so public resources, even if you have a friend who is a cancer specialist in this area, you can't just call them up. We need to be using published material that can be accessed online, or have otherwise been published. So we want material that you can trace it back to and say, okay, this is where your information about the chosen tumor type came from. Here's the typical treatments you would use. Here's the molecular data that we have on them. And this is why we did or didn't use this treatment. Why that was chosen versus other options. And for cases of it's not working, which is the case here, or it's not working as well, how you'll use what you know about this patient to identify the next thing to try, which could involve some cutting-edge research. Now, this is not something that we're expecting you to be curing a real-life patient here. It's not the same as when you're in residency and this is one of the patients that's in your care. This right now is about understanding the process of how to go about doing this, to demonstrate that you know and understand how to go looking for information here, and how the molecular targets interface with the treatment options. And if we look at the rubric, it's pretty straightforward, but you'll notice that the larger part of the points here, those 2 3-point the rows, are going to demonstrate an understanding of molecular targets and how it relates to therapies and history, and your understanding of novel therapeutic targets and evidence of reading the material. So since you have 5 points here, 5 numbered points here, and you have 6 to 8 slides, if there's something that you're going to spend 2 slides on, I would recommend starting with making sure that one of these things that gets the 3 points assigned to it is going to be one of those. All right, so let's talk now about how you might create a content outline that you start collecting your notes under. And at this point, if you are watching this on a recording, don't worry, we're going to look at this process a little bit more, but you won't find a slide on this because we're going into the working in a document. So now for planning out your presentation, you don't need to use our APA course paper template because ultimately this is going to end up in a slide deck for your PowerPoint or other presentation software of choice. So what we do want to do though is to make sure we understand exactly what is going in there. So I would say that most people recommend that you have an introduction slide, and that will have some things like your name, perhaps a summary. Some people even put some of the patient stuff on there, but yeah, an introduction, and if you merge that later, that's okay. And we also need to have a references slide. So as you add the citation, make sure you add to this references slide so that you have everything ready when you paste things in. So what might you have here? Well, probably your name, contact info, and something about the patient. Now, what degree of information? It's going to depend a little bit, and some of this will depend on the facility that you're in. Is this a board where these people are already familiar, or do you want to orient people even before you launch into the main body? So now, for patient privacy and other concerns, you're generally not going to be naming the patient, nor do you have to. So generally, age, sex, and then anything that is really important for orienting them. Now, I've picked here UV-associated Merkel cell carcinoma, which is a relatively rare form of carcinoma. And whether you're using an article that is from the reading for this module, or whether you're using an article from your external research, or even using something like ClinVar as a tool, tell us where that information is coming from, and start filling these in where the slides suggest that they should be. So a number of mutations that are associated with UV-associated Merkel carcinoma are these two, and let's say our patient has these. And let's differentiate between on diagnosis, they had this, mid-treatment, they also tested as having this, and our patient has unfortunately been going through a lot. It's a difficult disease to treat sometimes. Now, our poor patient has been accumulating a number of mutations here, and the important thing here is that we're seeing that there's an accumulation of mutations over time, and so this may cause the progression to accelerate. It may cause one therapeutic target to be less effective than another. So this one here, the CHEK2, so that's involving a tumor suppression gene. And I don't have to tell you that when a tumor suppression gene stops working or stops coding for something that is fully functional doing that thing it's supposed to be doing, that doesn't help your body's ability to attack tumors and prevent their growth and formation. So there's a lot going on. So if we're talking about a failure in treatment or a decline in effectiveness, then recently we've identified a thing here, then that's probably going to give you an idea for what the proposed resistance mechanism should be. Now, I do need to show my sources as soon as I start going into a discussion of the implication of these. So I have my article here pulled up in PubMed, and then I'll go to Cite here, and it'll give me one format, but I don't want this particular format. I want APA, because that's what my program is using. So, all right, I'll go ahead, and this is close. It's not perfect, but it's close. So we're going to copy this, and now we're going to take a look at our slides, or rather our plan for the slide. So reference, I'm going to start by pasting that here. Let's match the destination formatting, and we want to go ahead and change this to lowercase because in APA style, the title of a journal article is listed in the reference list as being in sentence case rather than in title case. All right. And so if whatever I'm writing about this, and then if there's a question, so where did that information come from? If your slide has this listed there, that's it. All you need to do is quickly bring up the references list and say, oh, there's the information on that. And so this not only helps the other people attending, but it helps you keep track of and helps you remember all these things, because the research is changing all the time as new things are discovered, new drugs and targets are identified. And so you will do yourself a solid favor by tracking each time you put in a point here that's going to be an item on your slide, that you track it in your notes. Now, do make sure to take a look at the reading for this week. There is, as you can see, a substantial number of articles that you can draw on that are talking about precision medicine and some specific instances of targets. So we have the thiopurine methyltransferase administration there. We have a discussion about molecular tumor boards if you're still wondering what to include. And in fact, we can go ahead and take a look at that now and see, oh, this is coming from this journal, Trends in Cancer. That's probably the kind of journal that if you're working on this, you would want to be reading, and because it's looking for what the new things are out. And so this gives you an idea of some things you might look at if you happen to be looking at a particular type of tumor that one of these trials has assessed. So for example, if you were to take peripheral T-cell lymphoma, well, lymphomas can lead to tumors, but if we were looking at leukemia on this list, then probably not. So just make sure as you're looking at this that it is something that tracks with the requirement that we be looking at tumors here. So now here we have, they're talking about a large percentage of clinically or potentially clinically relevant things. This is reinforcing the importance of understanding not only the cancer that the patient initially presents with, but what we know about their genetics and the cancer cells, so that you can identify treatments that will work with how they are at this point in time, which may change. So I promised that we would keep this under half an hour. So I'll finish by saying, if you are a pre-med student, I hope that this has served as an introduction to some of the terminology that you will encounter and to understanding one of the important organs, if you will, within a hospital today and within cancer treatment. If you are a precision medicine student, I hope that this has helped you structure your ideas and understand how to organize information as you proceed with this presentation. And for anything else, if there's a topic that you'd like us to present on, please feel free to send us an email at onlinewritingcenter@acu.edu. You can schedule an appointment by going to my.acu.edu, and under the additional resources, you can find the Online Writing Center, and you can go right to our website for videos, for templates, and other information.